Okay, this is the continuation of lecture on substance-related and addictive disorders, chapter 22. What I'm going to be doing right now is I am going to skip down to, I believe it's slide 9, so bear with me as I change slides. All right, I'm going to start right here. We didn't get to this part of the slide, suicide and alcoholism. That there is a risk for suicide when a person is intoxicated or high, especially when it's paired with a loss, such as being fired from work, being laid off, inability to find a job, loss of a significant other, divorce, separation, legal issues, OWIs, DWIs, or DUIs. Also possibly if a person has been caught in some type of other legal issue like fraud, etc. And why are they at an increased risk? Well, when a person is drunk, a person is high, many times they have disinhibition caused by the intoxication. And they may actually engage in behaviors that they normally wouldn't engage in if they were sober. So for example, a person who normally may not be the life of the party when they become drunk or high, they'll talk to anybody, they'll dance on the table. Okay, that's disinhibition. Likewise, when a person is may have loss in their life and they are intoxicated, those feelings of sadness, loss may be, and it may lead to, thoughts or feelings of, I'm a total loser, I have nothing to live for, and then a person might start to think about wanting to hurt themselves or do something to end their lives, and then oftentimes might impulsively take an overdose of pills or drive into oncoming traffic or do a variety of other things. Many times that I've come into work and a person was admitted for a suicide attempt with a increased blood alcohol level, and I'm talking with them the next day and they say, if I wasn't drunk, I would have never taken that overdose, or I never would have tried to hang myself, that sort of thing. Okay. So let's go on to the next area, and we're then going to be forwarding on these slides. And I want to start talking about treatment of withdrawal. These 5 things are standard in most withdrawal treatment centers. Monitoring fluid status, especially if the person is dehydrated. We want to be doing all those types of assessments for dehydration, but we want to encourage fluids. If the person has a lot of nausea and vomiting, can't keep anything PO down, can't drink, they may need to start an IV and then monitor that IV, but we want to maintain fluid status and monitor that. Magnesium sulfate, that is a medication that can decrease the irritability of the central nervous system and may actually prevent seizures. So you often will see that as a standing order. Vitamin B1 or thiamine in the multivitamin. This many times is given to anybody who comes in with diagnosis of alcoholism, but especially those in withdrawal. Many times they will have a deficiency of thiamine. We don't necessarily test for that, but we go ahead and treat that anyway, just because of if this is chronic alcohol abuse, they may start to develop Wernicke's syndrome or Korsakoff syndrome, and we want to prevent that. So we're giving that kind of as preemptively, just to kind of start, if they're starting to develop that, to treat it early. If they haven't started to develop it, they're probably lacking that anyway. But we know that alcohol interferes with absorption of B vitamins in the stomach, and so again, we're assuming that anybody who's is in withdrawal, they have a addiction and probably have had some interference with absorption. Benzos or benzodiazepines. This is a medication used in withdrawal. It helps prevent severe major withdrawal, or hopefully is going to prevent DTs, or the delirium tremens, and eventual seizures. We call this substitution therapy. Often what's given the most is Librium or Ativan. Again, it's a central nervous system depressant that is replacing the alcohol, which is a central nervous system depressant. So we're substituting that to calm down the nervous system so that we can withdraw them in a controlled environment. Number 5 there, you may also see other anticonvulsants being given for withdrawal, again, to prevent seizures. Now, just kind of a quick review. Again, why is it important for us to know when a person has had a last drink? Okay, if you go back up to the alcohol withdrawal syndrome, if somebody comes in and they have told us that they had their last drink at 8 in the morning and it's 9 o'clock in the morning right now, we are able to gauge when we think this person might start to get into minors, but also when they're going to get into major withdrawals, and then we can start to be looking for risk for seizures and risk for DTs and put into place interventions to prevent that. Likewise, if a person said that their last drink was 18 hours ago or 24 hours ago, we can start to anticipate that very shortly they may be going into major withdrawals, and we need to be ready for that and take proper interventions. The next slide is long-term treatment of alcohol when after withdrawal and detox is completed. Disulfiram or Antabuse, page 443 in your book, is a medication that deters drinking. If a person is on this medication and they go and take a drink, usually it will take 5 to 10 minutes, but the two, Antabuse and alcohol, interact with each other and cause nausea and vomiting, severe respiratory difficulty, headaches, diaphoresis, tachycardia, hypotension. They just feel miserable and sick. And what this is doing is hopefully this will help them to control impulse drinking. If they know they're going to get sick while they're on this medication, they take a drink. Many times that will prevent drinking. Now, Naltrexone is a medication, 445 in your book, that helps a person or helps to decrease cravings of alcohol and some other medications, but mainly alcohol. And also, if alcohol is taken, it can decrease the euphoria. Next class of drugs of abuse I want to talk about is stimulants. Obviously, they stimulate the central nervous system. Behavior is stimulated, and it can cause psychomotor agitation. Some effects: decreased fatigue, euphoria, high, greater mental abilities. It can, depending on the dose, it cause somebody to pay attention better concentration, better attention to details, increased heart rate, increased blood pressure, possible arrhythmias. If a person has a chronic use of stimulants, that can proceed into causing the person to have paranoia, hallucinations, and we find that oftentimes with methamphetamines. But stimulants have a very high abuse potential. Now, there are legal stimulants such as nicotine and caffeine. Many of us are familiar with those. Also, Dexedrine and Ritalin. These two medications, you need a prescription, but Dexedrine we also often find in diet pills that decrease a person's appetite. Ritalin is a stimulant used for ADHD. We'll talk more about that when we get into the adolescent and kids unit. Amphetamines or methamphetamines, also called speed, a lot of other names. This is very potent medication. Cocaine would fall into this category as well. Many times it's used in a binge and crash pattern. Bath salts, hopefully we'll see a video next class on bath salts, but this is a derivative of some of the amphetamines. They are it's basically synthetic stimulants, very similar to amphetamines, but they're slightly off on one of the chemical makeups. And if it's off one chemical, many times these can be sold legally because they haven't been outlawed yet. And that's why sometimes we see these bath salts being sold in head shops or gas stations. Long-term effect of all amphetamines can be, well, or is neurotoxicity. So therefore, we're talking about neurological damages to the brain, cognitive changes, which could be, the mental status changes we're talking about. These individuals can also develop skin lesions, hypertension. Treatment really is, when the person is going through withdrawal, when they're kind of crashing, is to give them, again, something to calm down that nervous system, but Valium and Thorazine. We'll be talking about the opioid crisis, and we'll see a couple of videos in class next week. But opioid use disorder is a narcotic. We have opiates, which are natural, and you see that opium was from the poppy plant, heroin, morphine. We also have opioids, which are synthetic narcotics, and you recognize those names that I have down there for you. Many of these are pain meds. Some of these are and are used as analgesics after surgery. Knee surgery, foot surgery. I was on hydrocodone for a couple of days. Even though I was given like probably a week prescription, I only used it for a couple of days, and it helped very much. But then I started to feel kind of sick with it, and stopped taking it after a couple of days. But my pain, of course, was not that great. Knee surgery, hip surgeries, shoulder surgeries. So for pain medication. And oftentimes people then who may develop chronic pain in their life may also be using these types of medications. There is tolerance that's built up and addiction, and people that come off this medication, depending again how long they've been on it, can have withdrawal of signs and symptoms. Effects of opioids, I mentioned before, they definitely cause a sedative effect, but also that analgesic effect. It desensitizes people to both psychological and physiological pain. And again, depending on the dose, can cause euphoria. Intoxication looks exactly like those symptoms that I had on there. You have you are conscious but sedated, drowsiness, out of touch, poor judgment, drowsiness, slurred speech, constricted pupils, have a high. Overdose looks like a person actually going unconscious, pinpoint pupils, and many times people will die from just shutting down of the respiratory system. But oftentimes we will see people coming in with respirations less than 10, pulse less than 40. The treatment here is for overdose is Narcan, which is a narcotic antagonist. Naloxone is another name for that, but it counteracts the respiratory depression. And you may have heard, in the past couple years, a big push for Narcan to be available to first responders and possibly family members, or those people who are likely to be around somebody who ODs on these opioids. They've also been exploring other routes like intranasal, as well as some other issues that are surrounding this. Fentanyl is another synthetic opioid that, when combined with heroin, is a very, very likely to cause overdose. The pattern of use here with these types of opioids is many times people will start out in a prescription, and then it can turn into start out as a prescription, become addicted, and then start to seek out that medication on their own or out in the street. Also, another pattern could be that people are using it for starting out with recreation. Withdrawal. Early signs and symptoms of withdrawal are muscle aches, restlessness, anxiety, teary eyes, runny nose, sweating, inability to sleep. Those are early symptoms. Later symptoms: diarrhea, abdominal cramping, nausea, vomiting, goosebump type skin, rapid heart rate, increased blood pressure. Now, what a lot of this, especially the early symptoms and the diarrhea and the cramping and that sort of thing, many times people will liken it to the flu. It feels like you have a really, really severe case of the flu. And that can be so uncomfortable that many times going through that withdrawal, people will not be able to tolerate it, or it's too uncomfortable, and therefore then will go back to getting back on the heroin or whatever opiate that they were using, and it just becomes kind of a vicious cycle where they cannot get off the medication. At 36 to 48 hours is where you see the most withdrawal, their most severe withdrawal, and then withdrawal can actually last for about 2 weeks, so it's not a short withdrawal, and that's also accompanied by craving of the drug. Mothers who or pregnant women who abuse and are addicted to opioids during pregnancy can have babies that are born with an opiate addiction. And these babies usually have digestive issues, poor feeding, dehydration, vomiting, and it may lead into seizures. And so you'll probably talk more about that when you get into third semester in your other classes. Treatment for opioids, we have buprenorphine. I'm sorry, I can't pronounce that. Buprenorphine, also called Suboxone, and please take out that Z and put an X in there, and Subutex. This Suboxone or buprenorphine is an opiate. However, it's not as addictive, so it's less likely to be abused. This medication will treat signs and symptoms of withdrawal and make the withdrawal shorter and less intensity. It's possible that it could be abused, but the likelihood is less likely to be abused. The length of it also decreases the length of detox, so that is one option for treatment. Another option for treatment is methadone, and methadone is a synthetic narcotic, and oftentimes it's used in long-term maintenance programs. And the idea with the methadone is that you're reducing the use of the person's opioids in a controlled manner by giving a substitute, and it can help with withdrawal, and then once the withdrawal is completed, then hopefully they can slowly decrease the methadone and eventually get off the methadone and the addiction altogether. Although sometimes that can be a very, very long process for individuals. Some people may actually never get off of it, and maybe a very, very long-term maintenance program. But with methadone, these individuals don't seem to have the rush or the high, and they also have a decreased cravings. Many communities will have what we call methadone clinics, where people who are off the illegal heroin and getting Percocet and that kind of stuff off the street. They're off of that, but they're coming into the methadone clinic every day to get whatever their prescription is from their doctor for that methadone. Okay, and hopefully the doctor is working with them for decreasing that, but again, sometimes that can take a very long time. Cannabis use disorder. Cannabis contains THC, which is found in the hemp plant. THC can be stored in let me switch the slide. Sorry about that. THC can be stored in the fatty tissue, detected in the body for up to 6 weeks. It depends on, although it depends on how long and how much THC is actually used. Some people will say that they can find THC in the hair up to 3 years. Again, it depends on how long and how much is used. We do know cannabis can have some analgesic effect. And can also help with nausea and vomiting in, after chemotherapy. So there are some proven medicinal effects. There are, medicinal effects also of decreasing seizures, possibly in some disorders. We do know that in moderate doses, cannabis can have a central nervous system depressant effect. In very high doses, THC and cannabis can cause hallucinations. Cannabis can cause psychological addiction and actual chemical dependency or physiological dependency, but it seems to take 10 to 15 years in adults for that addiction to occur. But for children or adolescents, that doesn't take as long, and physiological addiction can occur in only a couple of years. So like I said, addiction and tolerance can occur with chronic use. Some effects of cannabis: cardiac system, tachycardia, hypotension, respiratory system. Tar from the smoking can be deposited in the lungs, and with chronic use can cause respiratory problems. Reproductive system: with heavy use, in males it can decrease sperm count and motility, and in females can suppress ovulation. In the central nervous system, depending on the dose, a person can have that high feeling or drunk feeling, euphoria, very, very relaxed feeling. Again, depending on the dose, but with an increased dose, a person can have alteration in their senses. They can have alteration in judgment, especially with time and distance. And that's why we are concerned about those individuals who are driving while they're high on marijuana, and know that that can be a significant danger for the community. And right now they are still trying to develop a way that you can test for marijuana, person who's high on marijuana, just like you can with alcohol, getting a blood alcohol or breathing into a device for alcohol. As of yet, I don't believe they're testing things out right now so that we can do that. Long-term effect on the central nervous system is a person can develop a motivational syndrome, which has been documented and is a syndrome, and this actually is a decreased motivation and can affect the person's cognitive functioning. It can affect their memory, their ability to pay attention, to concentrate, and their ability to organize information in the brain. So there are significant effects of cannabis to many systems of the body. Okay, let's move on. Groups at risk I want to talk about here. There are, and your book doesn't really talk about groups at risk that I just want you to know about. Teenagers is one group at risk. And we know that because they're in the age of experimentation and peer pressure. Many people may use people who have difficulty coping with anxiety, that may be an increased use. Perhaps psychiatric patients who may be self-medicating for, say, self-medicating their voices, self-medicating anxiety. So they seem to be at a higher risk. Other groups: women, older adults, adult children of alcoholics, and healthcare providers. Now, why do you think healthcare providers might be at a higher risk for substance abuse? First of all, they do have extra stress in their life. As far as job-related stress, depending on what population you're working with, but many times nurses and healthcare providers are dealing with life and death situations which are high stress, or working with populations who may be going through stress themselves, working with cancer patients, working with chronic illnesses. So there can be high stress. And nurses also have easier access to many of these controlled substances or high potential for abuse substances. You guys are going to be talking more about substance abuse and nursing when you get into some of your leadership classes. Okay, going on to the next slide, we're talking about assessment. And we start with the nursing process, and we're going to be starting with assessment. So assessment, we just want to make sure that everybody is aware of, as we are when we work with any patients, but to have a non-judgmental attitude. And again, sometimes that can be easier said than done. So and we talked about that last class as well. So just keep that in mind. Make sure that you are being very self-aware and self-reflective of your practice and how your biases and values may impact the way that you care for individuals. So assessment, the first thing here, subjective. Need to be looking at page 433 in the CAGE questionnaire. So not only are we going to be doing this questionnaire, but also asking them about their feelings. But if you look at that questionnaire, it is, I'm just going to have you take a look at it. There's 4 questions that really kind of look at how other people have been viewing their substance use. But then also the last question has to do with, do you have, if you wake up, do you feel like you have to have an eye opener or something to calm your nerves? Usually if you're taking something to calm your nerves, first thing in the morning, that is a sign that you're going through some withdrawal. And again, and the recommendation is if the person has answers yes to 2 or 3 or more of these questions, that they should be further referred to more substance abuse screenings and thorough assessment. Common defense mechanisms we want to be looking for. I have 3 of those listed there, and we also talked about those in class. Motivation for treatment. We want to assess for that. Internal motivation, which is voluntary. This is obviously always the best motivation for treatment. They're going to have a better chance for success if they can identify that they have a problem and want help with it. We also have outside motivation or coerced motivation, which might be forced or it might be coerced by family, friends, doctors or providers. It might even be a court committal where they are actually forced into treatment. Now this chance for success is less. Obviously, if you're being forced to do something, many times you don't have the insight into that you have a problem, and it can create a lot of anger and resentment and just refusal, even though you are in treatment, refusal to participate. We also want to make sure we're doing thorough mental status exams in our assessment. Objective physical findings. So in class, when we talked about symptoms of liver cirrhosis, when we talked about physical effects of chronic alcoholism, I want you to know all of that for this physical finding. So I asked you to make sure you go through that outline and take notes on that. Also, we can do standardized questionnaires. I already told you about the CAGE questionnaire, but there's various other ones. I want you to know the CAGE, but you can skim through the other questionnaires. We also can be doing lab tests, blood alcohol, and I want you to know that table that I have in your notes about the blood alcohol levels and what symptoms you should be expected to see. THC can be monitored in the blood. Benzodiazepines can also would be a lab test that we can get. Liver function test, the increase in the AST and ALT are increased in alcoholism, as well as serum ammonia. On to the next slide. Nursing diagnoses. So for all these nursing diagnoses, it's going to be important for you to know why a person with substance abuse with substance abuse has these symptoms. What would indicate that we should give them this nursing diagnosis? In your book on page 434, table 23.9, goes over many of these nursing diagnoses. Now this nursing diagnoses are not necessarily limited to this list, and I'm going to go through some of these, but you can take notes on the rest of this. Risk for injury. This is going to be related to, especially for withdrawal, especially for alcohol withdrawal, because we know that there is a risk when a person gets into major withdrawal for them to move into DTs and possible seizures. Risk for suicide. We've already talked about this, but a person who's intoxicated and has loss has an increased risk for suicide. A person who is on a CNS stimulant may also be disinhibited and may be at risk for suicide. Ineffective individual coping. If a person is using substances to cope with their for stress in their life or coping with loss. Altered family process, and I have alcoholism there, but some of the other nursing diagnoses that would go along with this would be dysfunctional family process, and that would be for any substance abuse. But we know that substance abuse affects the whole family unit, and many times we have codependency and we have enabling behaviors within a family or with significant others. And this has to be looked at, so we have this diagnosis. Nutrition less than body requirements, fluid volume deficit. Again, we've talked about this, but many times people who are chronic abusers of substances are not eating properly. They're getting all their calories in through alcohol, or the alcohol is preventing, the proper absorption of B vitamins, so we can have malnutrition. We can also have fluid volume deficit. Decisional conflict, if a person is having trouble deciding, do I want to be in treatment? Do I not want to be in treatment? Do I have a problem? Sensory perceptual alterations would be those individuals who may be in either intoxication or withdrawal, who are having hallucinations. And it might be hearing voices or seeing things. Many times there's tactile hallucinations, people feeling like that, there may be bugs crawling on their skin. Denial is another nursing diagnosis, knowledge deficit. So I want you to look at those two. That I added those to your list, but those are in your book on that page 434. Outcomes. When we talk about outcomes, I want you to think about all these nursing diagnoses that we just have here. Oh, let me switch here. Outcomes. Think about what is the opposite of the nursing diagnosis, and that's what we want to see for outcomes. So risk for injury. We want a patient to go through alcohol withdrawal in a safe manner without any injury. Risk for suicide. We want a patient to be injury-free during their hospitalization, okay? Or to have no suicide attempts during their hospitalization. So you just kind of flip it. If the nursing diagnosis is ineffective individual coping, the outcome is that we want to see a person demonstrate individual coping mechanisms. And again, you can write that, in the proper way, but really we want to see them to have healthy, positive coping, appropriate coping mechanisms. Decision making is another outcome that we want to see. Appropriate decision making related to making choices about drinking or not drinking, making choices about putting themselves in high risk situations. Other outcomes, impulse control. We want to see that they are exercising impulse control by partaking, in, attending AA meetings, talking with their sponsor, etc. when they are feeling, lack of control. Risk reduction. What does this mean? Basically having the person understand and being able to verbalize what high risk situations would be for them. If I used to go out to work or out with my friends after work and we'd always go to the bars and drink, okay, this is a very high risk situation for you now that you're in recovery. Are you able to verbalize those, and then are you able to avoid those? Improvement of relationships is another outcome. Many people have alienated family members and significant others through their behaviors with their substance abuse, and we want to see some mending of those relationships, healing of those relationships, making amends to people. So we want to see that as an outcome. Lifestyle changes we also want to see as an outcome. And if you think about it, they are going to have to make a lot to reduce the risk of relapse. They are going to have to make a lot of lifestyle changes. They're going to have to avoid the bars. Maybe they're going to have to avoid certain family members. Maybe they're going to have to move out of the house because their wife is also an alcoholic, or the people that they live with are alcoholics, and it would be too high of a risk for them to move back home with those individuals. So they may have to change that part of their lifestyle. They may have to change the lifestyle of, going to family events where there's lots of alcohol or lots of substance abuse. And you can imagine, if you think about that for your own life, if somebody asked you can't hang out with your best friends anymore, you can't go to that wedding that has alcohol anymore. That can be very difficult, but those are outcomes that we need to see. Planning and interventions. First of all, with detoxification, well, let me just back up here. First, we want to make sure that we deal with the physiological symptoms. that the individual is having before we move into more of the psychosocial issues. Many people, after they go through detox, leave treatment. And again, unless they're court committed, that's their prerogative. But many people have difficulties going through detox. They come into the hospital or come into a clinic to get help with that detox and then leave. And then many times we'll go right back to that drinking. Now that's a kind of a vicious cycle that we don't like to see. And many times different studies have shown that people will relapse, go back to alcohol 7 times before they will actually then make a decision to get into rehab and be serious about rehab. So that is a lot of times. And so if we kind of keep that in mind when we're dealing with individuals, that can help us in a sense, maybe have a little bit of empathy for them or not be as judgmental. So let's talk about detox. We know that this goes with the nursing diagnosis, risk for injury. There's a variety of places where people can go for inpatient alcohol detox or other substance abuse. It might be that your hospital has a specific detox unit. It might be that this psychiatric hospital has a specific unit for it. It might be that you have your medical unit is what provides the detoxification. Excuse me. So we want to maintain a safe environment. And some of the ways that we're going to be doing it is providing those 5 interventions that I already talked about. They may be giving magnesium sulfate. They may be on a CWA scale, or I'll talk about that in a minute. But things to side rails up, how to seizure precautions, putting those things in place. Some other things that we would do during detox is if they have a high fever, we would want to give them ice packs, bring that fever down, have a nice, quiet, low stimulated environment. We would not let them really be attending groups, have a lot of visitors, but low stimulation. If they were having hallucinations, we would want to make sure that we are managing that with the proper medications, like with antipsychotics. We want to make sure they have adequate nutrition and fluids. They may need an IV, making sure that we are assessing their mental status, noting significant changes. Of course, taking vital signs and noting the changes in the vital signs. They may be on an I&O, bed rest. If they are having difficulty staying in a bed or if they're extremely agitated, we might need to have a sitter or a one-on-one. They might need help up to the bathroom. Neuro checks are going to be done. I talked about the CWA scale or CIWA assessment, and that is basically to help to monitor their withdrawal symptoms and then provide substitution therapy, like I said before, Ativan and Librium. And we're actually going to be doing a case study on this in class. We also have, let's move here to the next slide, intermediate care. And intermediate care is after the person has been detoxed and then they are maybe moved to a intermediate care. It might be an inpatient hospitalization treatment program, and these are kind of the basic things, the 30-day inpatient. Genesis doesn't have that. I'm not even sure if Robert Young has a 30-day inpatient treatment program right now, but various communities will have that. Some of them are paid, some of them are covered by insurance, some of them are not. But this provides a safe environment where they can start to begin to deal with their alcohol and their drug addiction. There's lots of group work that goes on here, lots of education, lots of focusing on their feelings and getting feedback from their peers and help from their peers. The next stage, if you will, is rehabilitation. After that, say they get out of a 30-day inpatient program. What happens next? Well, they're going to be in rehab, considered a recovering alcoholic or recovering substance abuser, but they're still going to need care and treatment. The focus in this stage is on teaching about the disease process and the recovery process. Now, just stepping back a minute, this might be in an inpatient facility. It might be an intensive outpatient facility where maybe the patient comes in for 8 hours or 10 hours a day and goes to groups and has structured programming, and then they go home at night to sleep. It might be just a day treatment program where they come in for 4 hours or 8 hours after work or before work. We also have halfway houses that provide rehabilitation where you're in, where they're, supervised halfway house, where there's rules and groups that are going on, some programming, but you're out, looking for a job or you're attending your job. So again, this rehab is, let me switch the slide again, is focusing on the teaching about the disease of substance abuse or alcoholism. What is that? What does it do to your body? What are the long-term effects? Okay, and then what is the recovery process? Also of note here is that this rehab treatment is needed for the whole family. It's not just a problem of one individual, but this individual is hopefully going to be going back to their family, and the family has to understand his need for a sober lifestyle and support for that, and a lifetime of non-use. And if family members can't be on board with this and help with this, then that might be a high-risk situation for them to return to their family, and that has to be considered. But the family has to be very, very involved. Okay, we want to make sure that we are building on the client's motivation for abstinence. And this is where they use a lot of coaching principles that we're not necessarily going to be going into, but what is their motivation for abstinence? Is so that they can help to raise their kids. Is it because they want to be a role model for their kids? Is it because they want to finish school or get back with their significant other? Okay, so really looking at what is the motivation for you to quit this and to be abstinent. Lifestyle changes. I already talked about this, but are you going to have to give up some friends? Are you going to have to give up some family members for a period? Hopefully it's not for the rest of your life, but for a period of time. Are you going to have to give up some habits of always going out to the bars after work, or always when you come home from work having a couple of beers, or hanging out with this person? What are those lifestyle changes that have to happen? Recovery process. Teach and encourage practice of recovery skills. Encourage some of these skills, encouraging verbal expression of their feelings, such as anger, depression, not just bottling it up and then going out and drinking or doing drugs, but encouraging other ways to deal with feelings. Assisting them to identify their stressors and areas of conflict in their life, and then teaching them ways to deal with that. Many people they know they feel stressed or that sort of thing, but bottle things up and are completely oblivious of, kind of that stress is going on in their life, or that they have conflict. As I said before, encourage coping strategies, really help them to get insight into their behavior. What does the substance abuse, what kind of behavior does that cause in you? Okay. And then how does that behavior affect your significant other? How does it affect your job? How does it affect the way that you relate to people? So really trying to get them to have insight. And then encouraging appropriate support systems. Get rid of the negative support systems, people that aren't helping you, people that are making you, putting you in risky situations to relapse, but having appropriate support systems. And that would include the 12-step, the 12-step self-help programs, AA, NA, Al-Anon. Al-Anon is for family members, but these programs emphasize total abstinence. Okay, once you're an alcoholic, you're always an alcoholic, and it has to be lifelong non-use. And then once that abstinence is achieved, then you go out and you help others that are having problems. Now, there are some people some alcoholics, some substance abusers that say that they can quit cold turkey, and once they've quit cold turkey, they can go and still be a social drinker. I can still go out and have one drink here, one drink there. And there may be people that can do that. I would say that that's pretty rare. So just, just be aware of that. But most 99% of people are going to need a lot of help and have that total abstinence and not be able to return to use. So AA, what does that do? What do these 12-step programs do? They sponsor other substance abusers. My sponsor. Basically what I'm saying here is that when I said that total abstinence and then you go out and help others, one of the things that the 12-step has is that everybody who's in the program is encouraged to get a sponsor or a mentor, if you will, but a person that you have a one-to-one relationship with who's also an alcoholic or substance abuser, who can help you through these 12 steps, who can help you when you're having cravings, help you when you want to go out and have a drink. But they can, and they're there for you at midnight or 2 in the morning or whatever. Okay, some other things of the 12 steps is teaching that there's no effective cure for addiction, but you're in lifelong recovery. Encourage the 12-step involvement, working through the 12 steps. And sometimes getting through those 12 steps can take many years, and maybe you have to go back and rework some of those 12 steps. Regular meeting attendance to decrease ambivalence, also to promote acceptance about never, getting into alcohol again or substance abuse, and again, looking at those addictive behaviors. Key elements, and I think we're on the next page here. Key elements is acceptance, surrender, processing, grief, higher power, and power of the group. There is emphasis on spirituality through meditation and prayer rather than your own willpower. Sometimes the spirituality or talking about a higher power or talking about God can be a barrier for some people. And so if a 12-step program may put somebody off or they don't like that, there are other support groups that don't follow a 12-step. But 12-step probably is the most common and most has been around, has had the most proven outcomes. 12-step also helps with changing the negative behavior and attitudes into positive behaviors and attitudes. Okay, so some other things with this that I wanted to talk about is codependency. And codependency is when a person is, and this kind of goes along with the family education and involving a family, but many families have a codependency element, and usually there's one person who may be codependent in that family that is enabling the alcoholic or enabling the substance abuser. Codependency is when a person achieves a sense of control by fulfilling the needs of others. They might feel that their household is very chaotic or things aren't going the way they want to, or there's a lot of anxiety, so they're going to control things by fulfilling other people's needs. And when this happens, there's a lot of boundaries that are crossed. Blurred boundaries causes a lot of dysfunction in the family. So for instance, a common example is just picking on a wife, but a wife who is codependent on her alcoholic husband. She feels like she has to meet his needs and make him happy. So maybe he comes home drunk, wakes up in the morning, has to go to work, but he is not waking up and he's totally hungover. And she starts to get into the routine of calling his work and making excuses for him. He can't come in today because he is has the flu today. Or she may overlook his, maybe some domestic abuse or physical or verbal abuse that's going on, because she says, well, it's just because he's having a hard time at work, but she's kind of in denial of the substance abuse. So this codependency, and she might walk around on eggshells not to make him mad, or keep the kids away from him while he's drunk or stressed out, so that we don't upset him and that sort of thing. So that's kind of that codependency. The person is looking at the other person's needs and not of their own needs. And they only find self-worth from the partner when the partner is happy, or when the partner's needs are met, or he's calm. So everything is done to make that other person happy. Okay. Client and family education, very important as well. Like I said before, this substance abuse affects not only the patient, but the entire family. Again, kind of going with that codependency, but the family often engages in behavior that enables the patient to continue the substance abuse. And the idea here is that we're trying to help the family see this and help and let the family know that you need your own support. You're going to have this person returning to you, but you are going to, from rehab, or maybe they're not seeking treatment, but the family needs help in this and they need their own support. Therefore, whether it be family therapy, Al-Anon, adult children of alcoholics. A big part of these rehab programs and client and family education is trying to anticipate relapse and putting relapse prevention strategies in place and helping them with the recovery, a lifelong recovery. So relapse prevention, let's see here. What else do I want to talk about with relapse prevention? This is basically where, go to the next slide, where a person has to be able to recognize what are high-risk situations for themselves. Those high-risk situations might be environmental, like going to a wedding with alcohol, or going out to the bars, or hanging out with this person. But it might also be emotional or interpersonal triggers or high-risk situations. Like every time I talk to my mom, I get so upset, I just turn to alcohol, or I have to go out and get high because I get so upset when I talk with her. But recognizing that, and then preparing themselves that I need to get coping mechanisms in place before, if I feel like I'm going to get into a high risk situation, I need to have coping mechanisms that I can choose that are healthy and not only resort to the drinking. So it might be that I can't see my mom unless I have another person with me. Because it's a high-risk situation, and I might have a tendency to go back to drinking if I get in that situation. Okay, that's just one example. A big part of these treatment programs, again, like I said, anticipating relapse and keeping away from those relapse triggers, or learning better ways to deal with relapse triggers, so relapse prevention. Some other general treatment strategies that are used in these rehab programs, let's see, I already mentioned self-help groups, lifestyle changes, education, confronting strategies. What might people need to be confronted with? If people are slipping, if a substance abuser is slipping back into using denial, they might need to be confronted about that. If they are slipping back into blaming other people, or just focus on memories of being high all the time, or drinking and all the good times, those might be things that need to be confronted. So another general treatment approach is confrontation with in those areas. Okay, and then the last part here is evaluation. And again, what are we evaluating? We are evaluating, did those people meet the outcomes? Was looking at the client's ability to change? Are they using better coping mechanisms instead of defense mechanisms? Are they able to avoid, high-risk situations and avoid relapse? Have their relationships improved? Is their family now have appropriate functioning? Okay. Be sure to look at the care plans and the various other things that are in your chapter 22, and that's all that I have. Thank you.